Welcome to our PED class. I hope you're doing well. Today we're going to discuss Down syndrome or trisomy 21. And our discussion should be able to look at the introduction, epidemiology, the etiology, dysmorphic features, clinical features, the diagnosis, complications, and management of Down syndrome. Let's look at a few terminologies here. Haploid cell contains 23 chromosomes. If a cell's chromosomes are an exact multiple of 23, these cells are referred to as euploid. Polyploid cells are those cells with more than the normal diploid number of 46 chromosomes. Therefore, except the gametes, the rest of the cells in the normal human body contain 43 chromosomes. Mosaicism is an abnormality defined by the presence of two or more cell lines in a single individual. You have this man, but in him some cells contain 47 chromosomes, while other cells contain 46 chromosomes. The most common cause of aneuploid is disjunction, which is the failure of chromosomes to join normally during meiosis. Non-disjunction can occur during meiosis 1 or meiosis 2 or during mitosis. Therefore, when you look at Down syndrome or trisomy 21, it's the most common genetic etiology of moderate intellectual disability. And the incidences of this trisomy 21 increase with advanced maternal age. What are the etiologies of Down syndrome? We have majorly three etiologies, and these also go as the types of Down syndrome. They explain how Down syndrome comes about. We have non-disjunction, which accounts for 95% of the cases. We have translocation, which accounts for 4% of the cases, and mosaicism in 1% of the cases. So let's look at non-disjunction. In our body, the cells have chromosome 1, 2, 3, 4, continues up to chromosome 23. But for now, let's look at chromosome 21. So during meiosis, the 46 chromosomes are reduced by a half to form an ovum or sperm with only 23 chromosomes. But in case this process is not completed successfully due to non-disjunction, some gametes are formed when they have an extra chromosome, whereas some gametes are formed when they have no chromosome. It means during meiosis, instead of these chromosomes separating and going to different cells, they end up going to the same gamete. So, in case this gamete here that has received an extra chromosome fuses with another gamete, of course, from the mother now or the other parent during fertilization process, the overall chromosome content in this offspring is going to have three 21s. The two 21s already from the same parent and one other 21 from another parent. Then they have three 21s, and that's what we call trisomy 21. Three chromosome 21s in the same individual. And then this results into Down syndrome. Therefore, there is failure of the chromosomes to disjoin normally. This occurs during gametogenesis, the production of a gamete with an extra chromosome. And the source of this extra chromosome, the maternal contributes 95% of these cases, then the paternal only 3%. And the recurrence rate increases with increase in maternal age. Then in the chromosome studies, you can have, for example, a baby girl with an extra chromosome. So instead of having the normal 46, she have 47 plus, of course, that one. Then also, you can also have a child, a boy, XY, but with an extra chromosome, 21. Then the other condition that explain the results of Down syndrome is translocation. So here, chromosome 21, for some reason, decides to get translocated onto another chromosome. Remember, in the body, we said each cell has chromosome 1, 2, 3, 4, 5, 6, 7, 8, up to 23. So in this case, chromosome 21 decides to get translocated. For example, with chromosome 14. So when translocates on chromosome 14, in the body, each chromosome has a short arm and a long arm. So the short arm of chromosome 21 decides to fuse with another short arm of chromosome 20 and chromosome 14. Then also the long arm of chromosome 21 and 14 fuse. So the short arms of these chromosomes being very short and they have no essential genetic material, they are easily lost. Then the long arms of the two chromosomes fuse together, making one long chromosome without any genetic loss. And in this case, if translocation occurs in the parent cell, he is a balanced translocation carrier. Therefore, this cell has already acquired an extra bulk of chromosome 21. Now, in case this parent now goes into the process of making babies, fertilization, we realize that another set of chromosomes is going to come from the other parent. Already, they have acquired an extra set of chromosomes. Another one is going to come from the parent, leading to Down syndrome. As illustrated in this diagram, already had a parent that was a balanced translocation carrier. And then you have another partner. So when they come together, when their gametes come together, in the process, some offsprings are going to be normal, some offsprings are going to retain the balanced carrier state, and then other offsprings are going to develop Down syndrome. That's another case that explains the appearance of Down syndrome. Then the final case is what we call mosaic Down syndrome. Here you have a haploid gametocyte from one partner and another haploid gametophyte from another partner. During the fertilization process, they have formed this embryo that has 46 chromosomes, which is totally normal. However, now for an individual to grow, mitosis takes place. So when the cell tries to undergo mitosis, non-disjunction occurs. There is a disjoining doesn't occur. In other words, therefore, some cells are formed with an extra 21 chromosome and other cells continue without this 21 chromosome. Therefore, they have less number of chromosomes. So this process continues in this individual, and this individual grows up having two separate line of cells within the same individual. So as explained here, that non-disjunction occurring post-fertilization during the first or second mitotic division, leading to the development of Down syndrome. So what are the clinical features? Mostly you have dysmorphic features, and dysmorphic features mostly affect the head and the neck, and the head, neck, and the extremities. not all of them are present in each affected individual. The impact of Down syndrome in each individual is individualized, with some individuals being profoundly impacted while others are healthy and able to live independently as adults. So in the head and neck, we're going to have open mouth, protruding tongue, featured mouth, short neck, excessive skin at the notch of the neck, narrow palate, abnormal teeth, etc. And all these features are also explained in these slides. You also have even microcephaly, small head, you have fine silky hair, low set ears, small mouth, protruding tongue, nose, small nose with depressed bridge. All of these and more features present in this infant. And also we also have a space between the first and the second toe. Then you also have hyper flexibility of the joints, and there is this transverse palmar grace which is present. Different systems are still affected. The CNS, you can have delayed mental development and others. Then cardiovascular system, you have different heart defects, including ventricular septal defects, patent ductus arteriosus, and others. And then also we have these features around the head and the face, including small flat nasal bridge, delayed fontanelle closure, and others. Then in the hands, most of these features we have seen them before already. We have seen this leading crease. We have seen this small wide gap between the first and second toes. We have also seen this one transverse crease, which is it. And also the GIT is affected, and features can include duodenal atresia, annular pancreas, Springs disease, can have perforated anus, and neonatal cholestasis can be present in these patients. And all these features are also summarized in this diagram. Sometimes you might have umbilical hernia, sometimes hypotonia, low set ears. So how do you diagnose this? Children with Down syndrome. The diagnosis is based on history, physical exam, and laboratory studies. However, the confirmatory test is done with genetic testing and mosaic Down syndrome. So, in prenatal period, we can do screening, and this test can help us to predict whether there is a high chance or a low chance of giving birth to a child that has Down syndrome. We can test for the maternal beta HCG, which will be elevated than normal. Then the maternal serum pregnancy associated plasma protein, which will be lower than normal. Then also we can do an ultrasound scan at around 11 to 14th week, and we check for the thickness of the nodule pad. It will be approximately greater than 6 mm, which is greater than normal. And then karyotyping is the only definitive diagnosis. So what are the complications? This syndrome almost affects all organs in the body, and therefore there are various complications that are associated with this syndrome. Immune deficiency, which is going to be characterized by increased risks of infection. Neurologically, you are going to have moderate to severe mental retardation, and you're also going to have atlantoaxial instability with a risk of spinal cord injury. And you're going to have congenital heart diseases, respiratory chest infections that are going to be recurrent, and also not obstructive sleep apnea. It's very, very common in these patients. Then you're also going to have renal anomalies and hypogonadism. Also have 20 times more chances of having acute myeloid leukemia. Also, sometimes they have diabetes and Addison's disease, even obesity and hearing loss. So, how do you manage Down syndrome? There is no specific treatment for this condition as you cannot correct the genetic abnormality. However, you try to predict the challenges, the complications that are most likely to be associated with this condition, and you manage the complications. So, timely surgical treatment of cardiac defects during the first 6 months of life may prevent them from being serious complications. Then also genetic counseling of the parents and educating them about the case and the possible progression. Treatments are based on the individual's physical and intellectual needs as well as his or her personal strength and limitations. General support can include good nutrition, vaccination, vitamin supplies, and then also management of the complications like said earlier. You can apply for rehabilitation as many of the cases of mental retardation. Then also physical therapy is okay. Speech and language therapy can also help this patient. Then occupational therapy. Otherwise, thank you for listening.